Ladies and gentlemen, my name is Miklós Ilyes. I am the president of the Hungarian Society of Arterial Stiffness, and I have been using arteriograph for more than 10 years. In the following, I would like to share my experiences how to evaluate the measured arterial stiffness parameters with arteriograph. First, the device shows you the suprasystolically recorded brachial pressure curve during complete occlusion of the brachial artery, such as stop flow condition. In this picture, you can see the separated first and second systolic waves from each other. This is P1 is a forward direct systolic wave, P2 is the backward systolic wave. And then you can see the diacritic notch, diacritic valley, when the aortic valve is closing and the systole ends. Then you can see the diastolic wave. It is worth to mention that during the suprasystolic recording, the first and second systolic wave is very nicely separated and very clearly separated and very easily recognizable. This is the fundamental basis of the operation of the arteriograph. The device provides the peripheral blood pressure data and peripheral pulse wave analysis as well. We can see the peripheral systolic blood pressure, diastolic blood pressure, pulse pressure, mean arterial pressure, and heart rate. The evaluation of the peripheral blood pressure is based on the relevant guidelines regarding the measurement and regarding the assessment and management of arterial hypertension, such as NICE guideline or European Society of Hypertension guideline. We do measure the brachial augmentation index. It is strictly correlates with the aortic augmentation index, so it is as informative as the aortic one. However, due to conventional reasons, we do not take it into account during the evaluation because the aortic augmentation index is used and being assessed in the scientific literature. For this reason, during the evaluation, we count with the central aortic augmentation index, not with the brachial one. The central hemodynamic part of the arterial stiffness measurement of the arteriograph can be seen here. The central systolic blood pressure evaluation is based on the long-term follow-up trial involving more than 4,000 subjects, and according to the receiver operating curve, 140 mercury is the highest level of the normalcy regarding the central blood pressure measurement, and then higher than 140 mercury, the central blood pressure is significantly prognostic for the later developing cardiovascular outcomes. As far as the central pulse pressure is concerned, we found the threshold to be 50 mercury, and if the central pulse pressure exceeds the 50 mercury, this is very prognostic for the later developing cardiovascular events. Let me remark that the 50 mercury is equal to the strong heart study data by Mary Roman, who also found that if the central pulse pressure increased more than 50 mercury, the parameters has prognostic value regarding the later developing cardiovascular events. The next parameter is the central augmentation index, which is normal age is less than 33%. Exceeding 33%, we can expect more cardiovascular complications and poor prognosis. Arteriograph can measure ankle brachial index as well. This an optional measurement. The evaluation of this measurement should be based on the relevant guidelines, which are clearly and nicely and widely obtainable. Ejection duration. The ejection duration is the mechanical systolic time, that is the time of the ejection of the blood into the aorta during systole. This parameter has no clinical importance nowadays because the generally used ultrasound assessment of the ejection fraction put it away, and then this parameter is not taken into account in the daily evaluation of the arterial stiffness parameters. If anybody would like to see the normal values of the ejection duration, it is available in the Weissler paper published in the Journal of Physiology in 1963. Arteriograph first pump to the diastolic pressure level and then to the suprasystolic one. At the diastolic cuff pressure level, we can obtain the diastolic pressure waves, and this is called volumetric pressure waves. During this period and during this observation, the flow is maintained during the whole cardiac cycle, and in this situation, large diameter changes can be seen in the brachial artery. For this reason, we call it volumetric or volume curve, because in this case, the whole length, whole volume of the brachial artery, which is covered by the cuff, contributes to the genesis of the signal. It is worth to mention that in the so-called diastolic cuff pressure signals, the first and second systolic wave cannot be seen because only one total brachial diastolic pressure wave can be seen as diastolic pressure curve, and no, you cannot distinguish the first and second systolic wave at the diastolic cuff pressure. The volumetric analysis uses three parameters such as diastolic reflection area, systolic area index, and diastolic area index. The diastolic reflection area is a complex parameter which describes the diastolic wave reflection intensity and the duration of the diastole. It is related to the diastolic filling conditions of the left coronary artery, which is mainly perfused during diastole. The evaluation is based on the value of the diastolic reflection area, which is normal if it is less than 40 units. Having higher than 40, we can expect more cardiovascular complications. From a physiological point of view, the longer the diastole, the better the left coronary perfusion. Consequently, if the diastolic area index is higher than 50%, it is beneficial. The second page of the arteriograph report contains the suprasystolic recording quality control. It is extremely important to record in a proper quality, otherwise we cannot obtain reliable results. The quality control is based on the analysis of the beat-to-beat measured aortic pulse velocities collected within the 8 seconds of the collection and recording, expressed in their standard deviation. The standard deviation obviously is low if the differences between the beat-to-beat measured aortic pulse velocity is small. It is acceptable if it is within 0.7 meter per second, which is the green range, and then if it is between 0.7 to 1, this is the yellow, which in this case we can take with cautious the measured parameters, and then if it is higher than 1 meter per second, which is falling into the red range, we have to repeat the examination. The next parameter which we can obtain by measuring with arteriograph is the aortic pulse velocity and the return time. The return time and the aortic pulse velocity are closely related parameters because the aortic pulse velocity is calculated on the basis of the return time and the distance traveled by the pulse wave. That is, pulse velocity equal sternal notch minus pubic bone distance divided by return time per 2. The evaluation of the pulse velocity and the return time are the next. We consider the aortic pulse velocity to be normal if it is less than 9 meters per second, and the return time is normal if it is more and higher than 124 milliseconds. This threshold again are coming from our survival study using receiver operating curve ROC analysis. The return time is as strong as or even stronger marker to predict future cardiac events like PVWV, referring to the fact that the distance measurement sometimes can cause human error bias. On the other hand, so the conventional acceptance today is for the aortic pulse velocity. So today the return time is very seldomly used in the scientific literature. For this reason, we also suggest to determine and to use in the description and the evaluation of the arterial stiffness report the aortic pulse velocity. In the coming parts, I would like to help you what to do, how to decide, what kind of steps, what kind of measures should be performed, having seen the different parameters which are exceeding the normal level measured by arteriograph. So what to do if we can find increased peripheral brachial blood pressure? We simply have to follow the relevant guidelines, such as European Society of Hypertension guideline, British Hypertension Society guideline, or NICE guideline. So we do have to follow the guidelines, how to evaluate the increased blood pressure subject. What to do in case if the central aortic blood pressure or the central aortic pulse pressure is increased. If the patient is under antihypertensive medication, we have to reconsider the given drugs, because beta blockers are not so favorable to reduce the central blood pressure. And then, despite of the nice lowering of the peripheral blood pressure and proper lowering of the peripheral blood pressure, the central blood pressure will not be decreased as we can expect. So in this case, if the patient is under medication with beta blockers and we found increased central pulse pressure and increased central aortic blood pressure, we consider to quit the beta blocker therapy or to change it to vasodilative beta blockers such as carvedilol and nebivolol or nebivolol. So high central systolic blood pressure and high central pulse pressure is provenly associated with very high cardiovascular risk. Furthermore, this is very important to mention that sometimes we find a young male subject who is suffering isolated systolic high blood pressure. And then if we wouldn't measure the central blood pressure, we would base on the peripheral systolic blood pressure. Slowly but surely we can start with antihypertensive drug, in the most cases unnecessarily. Why? Because the patient central blood pressure in most of the cases will be normal. So whenever we see a young subject with isolated systolic blood pressure, isolated systolic hypertension, high systolic blood pressure in young age, we should perform the arteriograph examination assessing the central blood pressure. Augmentation index. The augmentation index is related to the peripheral vascular arteriolar tone of the upper body above the level of the aortic bifurcation. The augmentation index is related to the vasoconstriction and the vasodilation of these small resistance arteries. In case of the increased peripheral vascular resistance, the augmentation index is increased. In case of decreased peripheral vascular resistance, the augmentation index is also decreased. These changes are determined by the nitric oxide synthesis of the endothelial layer. And this process, the nitric oxide synthesis, used to be deteriorated and damaged during early atherosclerosis. And we call this phenomenon endothelial dysfunction, when nitric oxide synthesis is diminished and peripheral vascular resistance increase developed. So because of the vascular resistance change are influencing basically the augmentation index, The measurement conditions, standard measurement conditions, are very important during the arterial stiffness measurement or arterial function measurement with any kind of technology, and also with arteriograph as well. What to do if we observed elevated augmentation index? We have to search to other, probably traditional cardiovascular risk factors such as smoking habit, obesity, dyslipidemia, increased serum glucose, hypertension, even masked hypertension or unproven and undiscovered hypertension, positive familiar anamnesis, sedentary lifestyle, and so on. So if these mentioned factors can show abnormality, we have to manage them according to the relevant guidelines. The positive influence and the positive management of the abnormal traditional risk factors such as quit smoking and changing lifestyle or decreasing the blood pressure can result improvement in the augmentation index, which by all means is positive. According to the available scientific data, we lack evidence concerning the positive effect of lowering the augmentation index regarding heart cardiovascular endpoints. Consequently, the direct modification of the augmentation index is still not a therapeutic target. However, due to physiological and pathophysiological reasons, the reduced vascular tone, the lower augmentation index, is equal to lowered cardiac afterload, which latter one is very beneficial in many pathologic conditions such as hypertension, diabetes, endothelial dysfunction, congestive heart failure. So, in case of elevated augmentation index in actively treated patients, highlights the need to reconsider the given applied therapeutic regime. Again, let me emphasize that the non-vasodilatory beta blockers might be responsible for the increased peripheral arterial tone and for the elevated augmentation index in hypertension. Most of the antihypertensive drugs have a positive effect on the reduction of the AIX because they are mostly having a vasodilatory effect. This is the exception is the beta blockers and probably the diuretics, which are more or less neutral. Some data shows that even they are having increased effect on the augmentation index. Taken together, augmentation index is a very early sign of the increased augmentation index is a very early sign of the developed endothelial dysfunction, decreased nitric oxide synthesis. Its positive influence, positive modification is very beneficial to prevent the further developing cardiovascular complications. Why? Because due to the increased peripheral vascular resistance, due to the increased augmentation index, the central blood pressure will also be increased. Thus, we will face against of increased central pressure load, which triggers the development of the vascular hypertrophy and the vascular calcification in the central arteries. What about the increased aortic pulse velocity and the shortened return time? They are going together, obviously. The aortic pulse velocity just tells us what about the characteristics of the aortic wall. The more rigid, the stiffer the aortic wall, the faster the aortic pulse velocity. Obviously, the stiffer aortic wall, the shorter the time of the pulse wave propagation. In other words, the pulse velocity and the pulse wave travels faster in rigid aorta, therefore the traveling time, so-called return time of the aortic pulse wave will decrease. The aortic pulse velocity cannot be considered strictly to be a constant, to provide a constant value, despite this is the most, let's say, predictive parameter in the arterial stiffness, and because it is influenced by some factors such as heart rate, stroke volume, blood pressure, cardiac output. because these factors are all increase the lateral tension of the aortic wall. Consequently, it will increase, and then it will be stiffer the wall, and it consequently increase the pulse velocity. Despite of these mentioned confounding factors, the aortic pulse velocity is strongly associated with adverse cardiac outcome and proved to be a very powerful and independent predictor of hard cardiac endpoints. However, as I have said, these kind of conditions during the measurement has to be kept and standardized, and we have to know that such heart rate, stroke volume, and blood pressure, cardiac output may increase and may change the aortic pulse velocity. Taken into account the above mentioned facts, elevated aortic pulse velocity detects asymptomatic subjects to be in high risk and refers to a more developed status of the atherosclerotic procedure when macrovascular target organ damage has occurred. Indeed, we have found a strong correlation between the arteriograph measured aortic pulse velocity and asymptomatic carotid atherosclerosis. On the other hand, we still lack evidence regarding if we would reuse the aortic pulse velocity directly, it would improve the cardiovascular outcome. Consequently, today, not the pulse velocity of the aorta is the therapeutic goal to treat, but instead we have to develop and we have to find the existing pathology that has to be cured and that would lead to increase aortic stiffness. So if we have high aortic pulse velocity, we do have to search for the signs of asymptomatic atherosclerosis. It is the most performed and technological method to perform carotid ultrasound. So, observing elevated aortic pulse velocity, an active search is mandatory to reveal macrovascular atherosclerosis. If the asymptomatic atherosclerosis is verified by carotid ultrasound, further steps in the management of the patients are clearly described in guidelines regarding the care of the asymptomatic subject with proven preclinical atherosclerosis. This can be found in the European Society of Hypertension and the European Society of Cardiology and BHS and other guidelines. The question comes up, what to do if an arterial function parameter is elevated, but we were not able to find any concomitant pathology? Because of the A-class evidence of the independent prognostic value of AIX and pulse velocity, furthermore, central systolic blood pressure, these findings have to be taken seriously. So we have to be aware of the fact that aortic pulse velocity and central systolic blood pressure and augmentation index, they are independent prognostic factors independently from the classical risk factors to reveal and to prognose further developing and future developing cardiovascular events. It is well known that the classical risk factors are fluctuating during the life, so it may easily happen that a certain moment during the measurement, normal values would be found. For this reason, the patient with abnormal arterial function but normal other results should be monitored and controlled regularly, because it is rather probable that during the next examination the hidden pathology will come to the surface. It is also very plausible that aortic stiffness may indicate earlier atherosclerotic damage before it could be detected by carotid ultrasound or other visualization method. Consequently, the algorithm should be the same as it was mentioned above, that is, the first positive arteriograph findings have to be followed by regular checkups. A cost-benefit analysis is the last point which I would like to touch in this evaluation. It is really difficult to be done and to perform, but it is obvious that the patient with abnormal arterial function parameters can easily be managed at the primary care level, which is more economic than to provide care to the patient with major cardiovascular events in hospitals. Furthermore, it can be realistically estimated that fewer events would happen due to the improved detection of and active preventive management of the high-risk subjects if we would perform a simple arteriograph evaluation. Concluding this issue, the arterial stiffness measurement provides us meaningful information about the early atherosclerotic changes, and following the already mentioned and already described algorithm, performing the necessary further examination such as carotid scanning, we can provide a very very nicely improved cardiovascular risk assessment, and we can prevent the transformation of the early damage to very severe cardiovascular events such as stroke, MI, and peripheral artery disease. Thank you very much for your attention.